session of body intervention. I'm honored to introduce Professor Dr. Nouruddin Abdelrahim Nouruddin from Frankfurt, Germany. He's one of the pioneers in the intervention radiology in the world. He will talk about CT-guided lung and mediastinal biopsy, step-by-step case series. Dr. Nour, glad to hear from you today.
Thank you, Mr. Chairman, for your kind introduction, and it's my pleasure to share with you our case series and studies in order to provide an obvious overview for the CT-guided lung and mediastinal biopsy. It's important to know that the decision-making for thoracic oncology depends on the concept of the multidisciplinary tumor board. And the most important data that they are required for the decision are the staging, imaging staging regarding CT, MRI, as well as the PET scanning, in addition to the histopathology of the lesion. And both informations are required for the subsequent decision of the treatment and management of the patient. And this way, this is the most important issue for to gain the histopathology, as well as the histopathology will also show us the molecular analysis in which there's a resistance of the tumor towards chemotherapy. So we need also an adequate biopsy core in order to provide a proper management of the patient. So how is CT-guided technique is done? So, of course, you know that the CT-guided is done, we have to put the patient either in supine, prone, or lateral position, depending on the accessibility of the lesion. And afterwards, we make a surface anatomy to detect the shortest access to the lesion. And after marking of the lesion on the surface, we start to make a disinfection and put the sterile coverings. Then we start our, of course, the patient should be well instructed about how to do how the intervention is going to be done. It's important to the patient compliance to be achieved. The patient should be quiet all through the procedure. While you are injecting the local anesthesia, please don't touch the pleura, particularly with emphysematous patients, otherwise they will get a pneumothorax. In most of the techniques, we have two techniques, either coaxial, non-coaxial system. In this video, you are showing the coaxial technique, in which we insert the coaxial needle at the edge of the lesion, and afterwards, you will have an access to the lesion. You can get multiple specimens from the same lesion, and in order to provide the pathologist with adequate histopathology. This is important not to repeat your biopsy. So what is the best position of the patients? So the best position is the most comfortable position for the patients. Your patient should be lying on CT table, very quiet. And this position is guarded by the accessibility of the lesion. The shortest access to the lesion is the most important and the best position for the patients. As you can see here, we have three patients. The left one is prone because the access to the lesion is here the shortest access. Intrapulmonary lesion, the patient cannot lie prone, so we can go in lateral position. And otherwise, if there is the patient lying supine, this is most comfortable for most of the patients. Which biopsy system is preferred and what is the gauge you are going to choose? We have two systems, either the coaxial or non-coaxial. The coaxial system allows you to do a single pleural puncture and to access the lesion without puncturing the pleura multiple times, so the risk of complications will be less, as well as you will get a diagnostic yield for the histopathology. The non-coaxial system is allows you to have a smaller gauge and less traumatic to the pleura and the lung parenchyma and less incidence of complications. So if you have a large mass like this way, so you can go through the coaxial system, you put the coaxial needle and you get multiple cores from the lesion. And if the lesion is a small, risky, like this parahilar lesion, you can get one biopsy specimen and you get out. For the needle gauge, we use in our institute 18 gauge. Otherwise, if their mass is large and directly lying on the pleura, traversing the lung parenchyma, you may use also 16 gauge. However, never use less than 16. The risk of complications is higher. What about the CT-guided biopsy from mediastinal lesions? Actually, we have two axes for the mediastinal lesions. The first one is the ventral aspect, which is the parasternal or retrosternal space, and the paravertebral or dorsal aspect. These are three cases that we also published regarding the how to access the anterior retrosternal or the anterior mediastinal mass lesions. Mostly are tumors like thymoma, like lymphoma, or in cases of myasthenia gravis, or so you are trying to get a biopsy from these lesions. The most important point is to take care about the internal mammary artery, because it lies around 1 centimeter from the edge of the lateral edge of the sternum. So if you crossing or transfixing the internal mammary artery, you will get a massive bleeding. I will show you a case of that. This is a case of a large lymphoma, anterior mediastinal mass. They are in need also the hemato-oncologist to the core for differentiation in which type of lymphoma, which is the histopathology of that, in order to provide the proper chemotherapy. And you can see that the coaxial needle system is away from the internal mammary artery. This is for a lesion lying subcarinal space, and it's lying in the posterior mediastinum. So in order to get access to this lesion, you have to get to the extrapleural space, away in the fat lamellae between the pleura and the spine, and you can inject saline in this way in order to make a hydrodissection, in order to create a potential space and to get the lesion. I prefer to go to this coaxial system, of course, because to inject the saline, and afterwards you can get multiple specimens from this lesion. Of course, it's sometimes challenging as you can get to the left side because of the presence of the descending thoracic aorta. Sometimes you get problem because of the presence of the azygous vein, or due to the presence of osteophytes, which may traverse or make an obstacle for your space. So now, what are the complications that may happen regarding the biopsy? We have the most important, the most common complication is the pneumothorax. We have two main factors, risk factors. One is avoidable risk factors, which you can avoid the risk of pneumothorax by planning the needle access to minimize the distance traversed through the lung parenchyma, and avoid multiple pleural punctures, so you can go through using the coaxial needle system, and avoid crossing major pulmonary fissures in the track of the needle, and of course showing multiple cases, and also increasing or improving the learning curve of your technique. You will refine your potentials and will minimize the risk of complications. Inevitable risk factors or high-risk group, these are lesion criteria like deep, basal, or small lesions. They are highly associated with the risk of pneumothorax and COPD and emphysema. I will show you some cases that associated with pneumothorax. This is an patient's had an emphysema. Of course, you can see that the needle track inside the lung parenchyma is only 1 or 2 centimeters. However, the patients developed a large pneumothorax due to the emphysematous pulley in between. So how to do? Don't get panic. You can insert an 8F big tail catheter, and you can in this way do manual evacuation using a 3-way stopcock, and you can evacuate the air. So no problem in this case. If there is continuous or persistent air leakage, you can put a chest tube. Most of the cases are mild cases, and an 8F big tail catheter is sufficient. This is another case of lung emphysema. Although we didn't traverse the lung parenchyma too much, however, the patient developed pneumothorax, as you can see here at the upper aspect anteriorly. The size of the lesion plays an important factor, particularly because of the manipulations done in order to access the lesion, because small lesions associated with the respiratory movement are difficult to access, and this will lead to more injury of the lung parenchyma, leading to more incidence of pneumothorax. As you can see in this tiny lesion, less than 1 centimeter, around 5 millimeters, and that's why such lesions are better to avoid, to puncture and make diagnostic follow-up in order to avoid incidence of complications. The other risk factor is the depth of the lesion inside the lung parenchyma. It's also associated with a higher incidence of a pneumothorax because you are traversing more lung parenchyma, you may injure more of the lung tissue. As you can see in this long track inside the lung, the patient's and a better access in this case is through the posterior or through the mid-axillary line, for example. Another risk factor is a deep or parahilar lesion. Actually, the patient has two risk factors. It's a deep lesion as well as there is also a pulmonary fissure, and this increases also the risk of the development of pneumothorax. Basal lesions are associated to higher incidence in pneumothorax due to the respiratory movement, and this will lead to increased incidence of injury of the lung parenchyma. As you can see here, this lesion lying directly on the pleura, we didn't cross the lung parenchyma, however, it's associated with a pneumothorax. This is also, this lung fissure traverses it, and this is an important risk factor. It increases the risk of developing pneumothorax 14 times in comparison to other cases. So you try to avoid traversing lung fissure. Every case in which I traversed the lung fissure, I had developed a pneumothorax. So please avoid it. Cavitary lesions are also risk factors for the development of pneumothorax. So just sometimes we have challenging cases like this way. A patient has a large emphysema, the lesion is lying over the descending thoracic aorta, and you're trying to get a biopsy from this lesion. So how to get a specimen from such a case? In this case, I decided to go also through the posterior aspect paravertebral. I made a dissection and to create a space between the lung and the posterior mediastinum, and afterwards I get a very short access through the lung to get the biopsy. This, what you see here, is the fluid as well as the air extrapleural, and it's not compromising or compressing the lung. So the protocol that we use for the management of pneumothorax is that as long as the pneumothorax is mild and minimal, less than 2 centimeters in CT, so you're not in need to intervene. Just follow up the case after 2 hours. If it is not increasing, so no management is required. Modern pneumothorax, more than 4 centimeters in 2 to 4 centimeters in CT, you can put an 8F an 8 big-tail catheter to drain the air manually. If there is a severe pneumothorax, it isn't required for a chest tube. This is a challenging case in which there is post-pneumonectomy, had a lesion. You don't know whether it is a metastasis or it is a new primary. So in such a case, never to done in outpatient principle. The patient should be done in CT in hospital, as well as the presence of a ready team like anesthesia in order to make immediate intubation if and compression of the lung due to complication. One of the serious cases that many doctors are not aware of this. This is a case had diffuse interstitial and infiltrative changes. We do not know which is a typical or atypical pneumonia, so they asked for biopsy. We did you can see that the lesion, the needle is at the surface here, and we didn't traverse the lung too much. However, the patient immediately after CT was agitating and was completely unstable. We did immediately a CT scan to exclude the presence of hemorrhage or pneumothorax, and what we see in this image, if you look very carefully, you will see the presence of air fluid level at the ascending aorta, and the patient developed a cerebral air embolism. So this is a fatal case. The only life-saving measure in this case is to make a reversed Trendelenburg position in order to dislodge the air pupils from the cerebral vessels. The other risk factors or complication that may happen with biopsy is the hemoptysis or pulmonary hemorrhage or hemothorax. The incidence is less than 5%. However, the bleeding could be focal or minimal like this case, or could be diffuse and opening inside into the bronchial system, leading to a massive hemorrhage. If you don't care about the internal mammary artery or the intercostal arteries, they may bleed fatally, and there's because of the suction effect due to the negative intrathoracic pressure. The small lung lesions are higher incidence of pulmonary hemorrhage. So if you have such a small lesion, less than 6 millimeters, so it's better to avoid not to take a biopsy. The materials are inadequate to diagnose through the pathologist, and also due to the movement of the lesion during the biopsy, the patient may get an hemorrhage like this case. And the patient developed bleeding post-biopsy, so it's better to avoid such biopsy in small lesions. Another factor is that the central lesions, because most of the vessels are converging around the hilum due to the alveolization anatomy of the pulmonary arteries. As you can see in this also, the second example. This case I told you this is due to angulation injury of the internal mammary artery leading to pneumothorax, pulmonary hemorrhage, hemothorax, and the patient, the hemothorax was increasing dramatically. The patient, we send it directly to thoracic surgery in order to clip the internal mammary artery. Basal lesions like pneumothorax, they have also increased incidence of hemorrhage due to the same effect, due to the movement of the respiratory movement and the effect of diaphragm on the basal lesions. As you can see also in this example. A long tract inside the lung also associated with increased risk of traversing the pulmonary vessels and increased incidence of pneumothorax. If you are going to make a biopsy, try to choose the shortest axis, the safest axis, in order to avoid such pulmonary vessels and to decrease the incidence of hemorrhage. The management of pulmonary hemorrhage is actually to stick to the rules. Avoid any not indicated cases. The contraindications for pulmonary biopsy is the bleeding tendency, thrombocytopenia, pulmonary hypertension, because you are actually depending on the coagulation system of the patient to overcome the bleeding. Avoid small lesions because they are small, the histopathology is inadequate, and also it's difficult and associated with more complications. For mild self-limiting cases, conservative or close observation, as well as the oxygen saturation and vital signs of the patient is immediate. If the hemorrhage is severe, like due to massive bleeding or massive hemoptysis, so there is compression of the lung, and this will lead to internal asphyxia due to flooding of the blood inside the tracheobronchial tree. So the most important life-saving measure is to put an endotracheal tube and make suction of the blood and keep the patient to the side of the bleeder, not to allow the flow of the blood to the contralateral side. This is one of our really This is after biopsy from a lesion which was a fungus, and you can see that this is the bleeding coming from the biopsy tract. And the patient was bleeding, and we were obliged to transfer the patient directly to the thoracic surgery to avoid such a bleeding. So I hope that I covered all the tricks and tips for such a case regarding the lung biopsy. Thank you for your attention.
Thank you. We will postpone any questions to the end of the session. Now Dr. Nour again has another